Good morning or afternoon, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Growth Hormone Replacement, Not Just for Kids, is being presented by Dr. Susan Samson. Dr. Samson is an Associate Professor of Medicine and Neurosurgery at Baylor College of Medicine in Houston, Texas. She is originally from Canada and completed her medical degree at Queen's University in Kingston, Ontario, and internal medicine training in her hometown of Calgary, Alberta. She moved to Baylor for endocrinology fellowship training and then joined the faculty. She is the medical director of the Pituitary Center at Baylor St. Luke's Medical Center, where she is part of a multidisciplinary team with Dr. Daniel Yoshor, Neurosurgery, and Dr. Mas Takashima, Otolaryngology, who are committed to excellence in surgical and clinical outcomes for pituitary patients. She currently serves on the board of directors of the American Association of Clinical Endocrinologists, and is a member of the Neuroendocrine and Pituitary Scientific community. She also is involved in training future endocrinologists as the Endocrinology Fellowship Program Director. Dr. Samson has a basic science lab and has also been involved as a site principal investigator for pharmaceutical clinical trials of therapies for pituitary disorders. She has been awarded the Fulbright and Jaworski L.L.P. Faculty Excellence Award for Teaching and Evaluation, as well as the Rising Star Award at Baylor College of Medicine. Her major clinical interest is pituitary disorders, including pituitary adenomas, hypopituitarism, Cushing's disease, and acromegaly. Thank you so much, Dr. Samson, for your involvement in our webinar program. There's going to be a brief delay as we change presenters. Dr. Samson, you should see on your end a request to accept.
I can see that. Can you hear me?
Yes, I can. Hear you very clearly.
Excellent. Excellent.
Okay.
I'm just sharing my screen.
I see it now. It looks great. Sound is good. It's all yours.
Thank you very much. Well, I'm really excited to do this presentation for you and the members of the Pituitary Network Association this year. I gave a presentation a few years ago, and I'm glad that I was invited back. So I wanted to talk a little bit today about growth hormone therapy in the context of adults with hypopituitarism. But first, just a little trivia since I'm sitting here in Houston, Texas. This here is J.J. Watt. He is our defensive end for the Houston, Texas. He stands 6'5", 240 pounds, and is a phenomenal athlete, having won Defensive Player of the Year 3 times in a row for the NFL. Standing beside him is also a world-class athlete. That's Lionel Messi, who is from Argentina originally and had such talent as a footballer that he was taken to Spain so that Spain could pay for growth hormone therapy, as he was growth hormone deficient as a child, and is regarded as one of the greatest footballers of all time. So if you think there's a big height difference there, then you've got to look at J.J. Watt in the context of Yao Ming, who also played in Houston for the Rockets and stands 7'6". So I'm not really sure completely what the genetic, environmental, and nutritional contributions are to height, but this is an interesting sports trivia. So what this talk is not going to be about today. We're not going to talk about treating children with growth disorders. I am not a pediatric endocrinologist. I work with adults. It's not going to be about athleticism or bodybuilding or supplements outside of the FDA-approved uses of growth hormone. It's not going to be about somatopause or the decrease in growth hormone as we age, and growth hormone being a fountain of youth. My objectives instead today are to talk about the actions of growth hormone, discuss the possible symptoms and clinical consequences of growth hormone deficiency in adult patients, identify how we can test for this, and then to look at the current evidence on what are the risks and the benefits of using growth hormone in adults with a specific view to patient-specific characteristics that help us decide as endocrinologists whether this therapy would be of benefit to our patients. So just a brief review, what is growth hormone? Well, I think a lot of us would understand that this is a pretty important hormone when we are going through childhood as we grow, and then once we reach our full height, understanding what growth hormone does in the body has been a little more challenging. The growth hormone is a peptide or protein hormone made in the pituitary gland. Here's a little schematic of the pituitary gland here. And its secretion is tightly regulated by circadian rhythms, in other words, day and night. And most patients will have growth hormone levels that rise during deep sleep. Growth hormone is also activated by physical activity or exercise, emotional stress as well. So growth hormone is regulated by the brain, this area up here in the hypothalamus, by growth hormone releasing hormone. And that then communicates with the pituitary to release growth hormone. Another hormone called somatostatin is an inhibitory hormone for growth hormone release. And so there's a type of relationship or yin and yang and communication among these different hormones to regulate the release of growth hormone, which is pulsatile and regulated by circadian rhythms. So what does growth hormone do? Well, it is released by the pituitary and goes through the circulation to different tissues, including the liver, to make a hormone that is called insulin-like growth factor 1. Insulin-like growth factor 1 is not insulin, but it has a structure and its receptor are very similar to insulin, and that's why it received this name. An old-fashioned name for insulin-like growth factor is somatomedin C. So you may see this in lab tests, or you may see this when you do reading about growth hormone. Insulin-like growth factor is really the protein that circulates and has most of the effects of growth hormone on the body. For example, it can affect skin, connective tissue, cartilage and bone, as well as the organs. Growth hormone itself can also have effects on glucose homeostasis. What do I mean by that? Well, it can affect how well your body is able to use glucose. It can cause you to have more insulin resistance if it's elevated. It also affects calcium metabolism, which can affect bone density and bone health. And it can also cause lipolysis. So lipolysis is the breakdown of fat in the body. So you can imagine that growth hormone also has effects on body composition with regard to how much fat mass or lean mass a person might have. So we all understand growth hormone is important in children for growth. This is an example of a chart you might find in a pediatrician's office. This is a growth curve for a girl who, over time, the pediatrician will track the growth of the patient, and if the patient falls off their particular track line, they need to be investigated for causes of growth hormone deficiency or other diseases that might be causing decreased growth. But what about in adults? Do we really have any information on the importance of growth hormone in adults? This data looks complicated here, but it is looking at patients in all of these different studies who have hypopituitarism or low pituitary function. And what you can see is that if you have low pituitary function, you're at risk for a higher mortality rate than someone else who is matched to you for age or sex. So if one means that this is a normal lifespan, as the number increases, this is a higher mortality rate. So in patients that have hypopituitarism, there is a documented higher mortality rate, which we know from these epidemiologic studies. Now remember, these are not clinical trials that tell us this. This is just taking a large amount of data from a cohort of patients. What is interesting is this is happening even if the patients are on full replacement. That might mean they're on a steroid such as hydrocortisone for their adrenal gland. They may be on thyroid medicine. and they're on sex hormones, for example, being on estrogen or testosterone if they are a deficient patient. And if growth hormone is not replaced, that standardized mortality ratio still exists. That is not to say that growth hormone is definitely the culprit here, but it does provide us with some information that growth hormone may have an impact on our lifespan. And what's even more interesting, again, if you look at these different studies, some of them with very large numbers of patients, if you look at studies without growth hormone treatment and the increased standardized mortality ratio, here, for example, of 2.4 in patients that do not have growth hormone treatment but have hypopituitarism, and then you look at these two studies where they did have growth hormone replacement, you can see that the standardized mortality ratio for these two studies was nearing 1. In other words, decreased mortality or similar mortality to someone else who does not have hypopituitarism. Again, this is not direct evidence of benefit, but it certainly is intriguing to think that there may be an impact of growth hormone for these patients. So what are the causes of growth hormone deficiency in adults? First, if you had childhood growth hormone deficiency and that particular issue has not been resolved, for example, you may have congenital growth hormone deficiency and that will carry on through the teens and into adulthood. Also, children who have undergone treatment for cancers, brain tumors, things near the pituitary, which could include surgery or radiation, this also can then result in growth hormone deficiency into adulthood. But what about adults who did not have a childhood reason? We know that there can be physical damage to the pituitary by pituitary tumors or tumors in the area, such as a craniopharyngioma. We also have data on radiation, and I'll show you a slide about that. There can be other diseases that infiltrate the pituitary and cause it not to work as well, including inflammation, infection, certain types of cancers. And we're learning more and more about what trauma and traumatic brain injury can do for growth hormone deficiency. So for example, if this is a normal appearing pituitary gland, and I train my fellows to see this looks like an anchor here. Here's the pituitary stalk, here's the pituitary glands between the two carotids. Someone with a tumor of a pituitary adenoma here, this is one of my patients from clinic, you can imagine that that anatomy has now been compromised by that tumor and that patient would have growth hormone deficiency. We also know that radiation impacts the pituitary. And the radiation doesn't necessarily have to have been for the pituitary itself. It may have been done for other different types of cancers like nasopharyngeal cancers or other tumors, but the pituitary was in the area of that radiation. Now I do sometimes use the analogy with my patients that the pituitary is like a bowl of M&Ms, with each color making a different hormone. It's not completely true, but it does help patients visualize that there are a number of different types of cells within the pituitary gland. And what we know from this very classic but old study, that with external beam radiation, there is a hierarchy of how each of these different types of cells are able to handle the radiation damage. And you can see here that one of the first things that is lost in this particular cohort is growth hormone by 5 years. We're also learning more and more about traumatic brain injury. In the U.S., over 1 million people are treated per year for traumatic brain injury in emergency departments and released. A large number are also hospitalized, and some will pass away, unfortunately. And of those that have severe brain injury, they can develop long-term disability. Now, the types of injuries that can cause pituitary changes include motor vehicle accidents, which take up about half of the causes, but also falls, someone being subjected to violence, and then, of course, there are sports, and for people who serve, combative and blast injuries can also occur. And what we know that for those who survive greater than 12 hours after a traumatic brain injury, many of them have areas of the gland that have died because of the lack of blood flow. I'm showing a complicated picture here, but if you see up here is the brain, and down here is the pituitary. And here, which I've drawn this red circle, is the diaphragma cella, which kind of separates those two areas. You could see that the blood vessels that feed the pituitary gland are transversing that line. And you can imagine, and I describe this sometimes as a little tiny punching bag, that with a sudden movement or traumatic brain injury, that you may have shearing or rotational damage to this little gland, an interruption of the blood supply with loss of oxygen, and perhaps even bleeding and cell death of pituitary cells. Also, because the brain is so important for communicating with the pituitary gland, it's thought that there may be decreased communication of trophic or growth factors that keep that pituitary healthy, and that decreased communication can also have an impact on pituitary function. This study here was very interesting, and you do not need to focus on the graphs, but the most important thing was that we can see changes after traumatic brain injury at even up to a year versus 3 months after the injury. So for example, you may have multiple pituitary hormone deficiencies at 3 months, but some of those may resolve and some may actually appear later and get worse. So it is important for us as endocrinologists who see these patients to make sure that we follow these patients longitudinally and are looking carefully at their pituitary function. And here, the #1 deficiency that showed up in this study, again, was growth hormone. And I showed you my bowl of M&Ms, and I told you that's not exactly true. The reason there's more risk for growth hormone is that a lot of the growth hormone cells are more in the periphery here of the pituitary gland, and that is the area that loses more blood flow if there is damage to these blood vessels. This particular, I guess we would call it a meta-analysis, but they're looking at all of the different studies that have looked for growth hormone deficiency after traumatic brain injury. It looks like about 10% of these patients may manifest growth hormone deficiency. So it's not everyone, but it is a percentage that causes us to pause and think about testing our patients who have been through TBI. And again, as I brought up, we're learning more and more about the effects of blast injury in patients who have served in the military. For example, in this study by my colleague at Emory, you can see that almost 1/4 looked like they may have abnormal growth hormone stimulation when they have a history of blast injury. And of course, we still need to learn more about the effects of sports and recurrent injury and whether that is the same mechanism as one traumatic brain injury. We're really not clear at this time if even headgear for people doing these kind of sports that have repetitive head injuries can reduce the risk. And of course, that would also bring up the controversy if an athlete becomes growth hormone deficient, what are the ethics of replacing growth hormone in an active athlete? So who do we test for growth hormone deficiency? Well, we test those that you might treat. So you don't need to go testing for it if it's not someone that you feel would benefit from growth hormone. And that might be someone who has symptoms that could be attributed to growth hormone deficiency and include patients who have childhood onset growth hormone deficiency. You might test someone who has a known tumor or history of tumor or radiation in the area of the pituitary. And again, as I just brought up, patients who may have a traumatic or repetitive brain injury. You would not test those that you would not treat. I will not test someone who has an active malignancy, someone whose diabetes is out of control and I need to do better at helping them get that into control, or patients that have known diabetic retinopathy or the effect of diabetes in the back of the eye, because it is possible that growth hormone can have a negative effect on diabetic retinopathy. The other thing is I always make sure that I have really optimized the thyroid, adrenal, and sex hormone replacements in patients that have hypopituitarism to make sure that I have been able to get them to the best place possible with their replacement. So how do we test? This has become a real challenge because if you think about it, in a child, we know someone has growth failure. They're not growing anymore. We give them back growth hormone and they start growing. But what is our biologic endpoint in adults? Also, the other thing that complicates things is growth hormone is secreted pulsatile or episodically, and those levels are modified by age, by our sex, are we male or female, and by our body mass index. So it can make it even more challenging to interpret, is this patient growth hormone deficient? So I told you before that growth hormone comes from the pituitary, circulates, and causes tissues to make insulin-like growth factor 1, mostly coming from the liver. Now, the nice thing about IGF-1 is it doesn't pulse like growth hormone. It is a much more stable measure of growth hormone secretion. We use the term integrated measure because it is more stable in circulation. So if I draw the blood of a patient and do an IGF-1, it gives me a much better idea of how their growth hormone activity is than measuring random growth hormone. If the IGF-1 is actually low in a patient for their age and their sex, and they've lost the other pituitary hormone axes, to me, this is very specific for growth hormone deficiency, and I shouldn't need to test any further. We have to be very careful when we interpret IGF-1 in patients with diabetes or liver disease or estrogen therapy, because that can influence the levels. But one of the issues with IGF-1 was revealed in a very classic study by Dr. Baylor from Harvard. They looked at a number of ways of testing for growth hormone deficiency. And if you look at the graph on the right from this paper, patients here who had multiple pituitary hormone deficiencies, in other words, you would expect them to be growth hormone deficient, and patients who had no problems whatsoever, this IGF-1 level that was used overlaps significantly between the two groups. And so one of the important details of growth hormone replacement to come out, or growth hormone testing to come out of this paper, was that you can't always trust a normal IGF-1 in patients in whom you suspect that they may have growth hormone deficiency. And so that is where our Endocrine Society, ACE, the Growth Hormone Association recommend dynamic testing, which is our more complicated test, which I'll go over a couple of them, if the IGF-1 is normal and you really suspect this patient has growth hormone deficiency. Sometimes, as a physician, it can be quite frustrating. This issue may be somewhat unique to the United States, but we seem to have a lot of requirements from insurance companies for how to prove growth hormone deficiency, even when we feel as physicians this has been adequately proven. So sometimes insurance companies will require more dynamic testing than we even expect. And the Growth Hormone Research Society states that one growth hormone stimulation test is sufficient. But which one should we use? Well, when I was a fellow in training, the insulin tolerance test was used commonly. It was the gold standard. And it's based on the concept that if you induce low glucose or hypoglycemia in a patient by injecting them with insulin, you will be able to see the stimulation of growth hormone. Because growth hormone and cortisol, shown here on the teeter-totter, are counter-regulatory to insulin. In other words, if your glucose goes low, growth hormone will rise. And so this test helps us to understand the ability of the patient's pituitary to respond to the stress of low glucose or hypoglycemia. Now you can imagine that this has to be done under physician supervision. You're making somebody hypoglycemic. It can't be done in patients with a seizure disorder. And you want to consider in elderly patients or others who have risk for heart problems like angina, Would we do this test? Probably not. This test has been more and more difficult for us to do in the clinical setting. As medicine has evolved, especially in the United States, it becomes hard for physicians to have the time to supervise what could be a 2 to 3 hour test. Some centers are still able to do this. Additionally, a lot of nursing regulations are not very enthusiastic about causing hypoglycemia in patients. Now, these are all the other tests that we have looked at over the years. Again, this is from Beverly Biller's classic paper. I do want to say this looks complicated, but the point of it is there is no perfect test here. For example, we used to use the arginine growth hormone releasing hormone test to test for the peak of growth hormone in deficient patients. Unfortunately, the company that made growth hormone releasing hormone for the U.S. Stopped doing it, and it has not been available. So this test has not been used because of that. Additional tests are a lot weaker stimulation. These are amino acids, and amino acids can stimulate growth hormone secretion, but it's really not a robust test. And finally, I already told you the problems with using the IGF-1 in some patients, that there is significant overlap with normal patients, even in deficient patients. So what I'm telling you is this slide just serves to tell you that it is very challenging as an endocrinologist to find the right test for our patients. More recently, I have started using the Glucagon Stimulation test. There have been some excellent publications by my colleagues. This is Kevin Yoon from Swedish clinic in Seattle, and others have published on this test, and I have found that this is the test that I am currently happy using. Glucagon, I showed you that teeter-totter before. Injection of glucagon also stimulates growth hormone. For some reason, when you give glucagon, liver glucose increases, and then that causes a reaction in the body, possibly with insulin release, and there is a fall in glucose. So patients can actually have late hypoglycemia or low glucose with this test. Patients should fast overnight, and then the glucagon is injected in the muscle, some studies subcutaneous. Unfortunately, this is a super long test. It's 3 to 4 hours long in order to get all of the data you need on the patient. And patients can have side effects, including nausea and vomiting, headache, or low blood pressure. But there are some studies showing us that it could be almost as good as the insulin tolerance test that I showed you, which is our gold standard from years previous. And most published studies will say that growth hormone levels, if you can achieve a level greater than 3, that will rule out growth hormone deficiency. However, the glucagon stimulation test still requires more vetting in the literature because we have not fully evaluated it in specialized populations, which include the elderly, those with diabetes and insulin resistance. And one thing that is becoming more and more apparent is that if patients are overweight or obese, the glucagon stimulation test can overdiagnose growth hormone deficiency, and we may need to reduce that cutoff from 3 down to 1. Why do we care about growth hormone deficiency in adults? Well, we know that patients who have adult growth hormone deficiency have decreased bone mineral density, which can translate to changes in bone strength. There can be changes in body composition, like increased abdominal fat or central fat, and decreased lean muscle mass. Also, beyond muscle mass, there may be decreased muscle strength and aerobic capacity. And sometimes cholesterol or the other parts of the lipid profile can be elevated, which is a risk factor for cardiovascular disease. There also have been studies looking at quality of life for patients who have true growth hormone deficiency. They can have low energy, they can feel socially isolated, and what we need to look at is, does growth hormone ameliorate these symptoms? So first, let me talk about bone density. Growth hormone and IGF-1 regulate bone growth and metabolism. It's what you would call anabolic or building. So they stimulate proliferation and differentiation of bone-building cells. They may also increase bone remodeling. So even though the bone has been laid down, it needs to be remodeled to make it stronger. We know that adults with growth hormone deficiency and low pituitary function have 2 to 5-fold higher bone fracture rates. Now, this could be partly due to growth hormone. It could also be because of how we replace other hormones. For example, thyroid hormone, hydrocortisone, or other corticosteroids can also affect bone. This is a study from the Netherlands which looked very long-term. If you look here, baseline, 5 years, 10 years, 15 years, at patients who received growth hormone replacement who were deficient at baseline. And you can see here in the spine that there is a slow increase in bone mineral density in males. This difference was not seen in females. And in the hip, which is what this is referring to, left femoral neck, did not really see a significant increase. However, there are other studies that have shown increases in bone mineral density with growth hormone therapy, but that requires at the least 12 to 24 months of therapy. Growth hormone can also alter body composition. As we said, deficiency causes increased abdominal fat. Increased abdominal fat, decreased lean mass, and can cause abnormal lipids or cholesterol, triglycerides, and decreased muscle strength and aerobic capacity. This is a diagram from an excellent article by Dr. Grinspoon, who is a world expert on growth hormone. What it's really talking about is how reduced growth hormone might contribute to the changes in abdominal or visceral fat, but those have an impact on your lipids, inflammation, and of course always on cardiovascular disease risk. This is a study that showed that in the adult growth hormone deficient cohort, there was increased cardiovascular disease risk versus the general population, which are age and sex matched. There's also other risk factors such as obesity, high blood pressure, elevated cholesterol, and diabetes, all of which contribute to cardiovascular death that were deranged in patients with growth hormone deficiency. The Dutch National Registry of Growth Hormone Treatment in adults with growth hormone deficiency showed that there is a significant change in lean body mass. In fat mass, there's the minus, so they lost fat in kilograms, decrease in total cholesterol, decrease in LDL cholesterol, which were all significant in growth hormone treated patients versus those who did not receive growth hormone. This is another study where you can see the decrease in that central fat in both men and women who are treated with growth hormone versus placebo. And similarly, decreases in LDL cholesterol, which is the bad cholesterol that is the culprit for cardiovascular disease. This is a very, very small study, and I'm hoping there will be a randomized control trial at some point looking at fatty liver, which has become an epidemic as we have become more and more obese in our society. And in this study, they did look at a few patients, and the liver fat percent by imaging decreased after growth hormone treatment. We also know that there is increased exercise capacity measured as VO2 in patients on growth hormone. These are all different studies, and this here is a positive percent change in many of these studies. Not everyone showed significant benefit, but there are a number of studies supporting that there may be increased exercise capacity with growth hormone replacement in adults who are deficient. And when somebody pooled all the data of 15 trials, they were able to show that this exercise capacity, or VO2, was significant, that they increased muscle volume. But what was interesting is there was no increase in muscle strength when all of these studies were pooled together. Remember, I also raised the concept of quality of life in patients, those intangible things that the patient feels but the doctor can't quantify. There are several different surveys that have been used throughout the literature. This is a very long list. Some show benefit with growth hormone, some do not. But certainly the literature is full of assessments for quality of life. There's even a quality of life, an adult growth hormone deficiency assessment specifically for this medical issue. We do know that when patients have a baseline, that there is decreased sick leave, decreased hospital days, and decreased visits to doctors among patients who have growth hormone deficiency and then start treatment. So how do we use growth hormone safely? This is a hormone. We have to be very careful about how we use this. It has salt and water retaining effects. It can have effects on water retention, where we see edema or water fluid in the tissues. This can worsen nerve entrapment, where you have tissue that swells, such as the carpal tunnel, and causes more symptoms, such as tingling from the nerve entrapment. Growth hormone can reduce insulin sensitivity, and what that can lead to is an inability to dispose of glucose, and so diabetes can worsen or manifest. And cell growth and proliferation, theoretically, is promoted by growth hormone. So one of the concerns has been, could there be progression of a tumor that you don't know about, or a cancer, or could this even encourage a new cancer? With regard to data on diabetes, the incidence of type 2 diabetes in growth hormone studies is either the same, so no effect, or mildly increased. And when you actually look at the studies who reported it, it was about 17%, 0 to 17% developed type 2 diabetes. Many of those patients had already had other diseases from the pituitary, including Cushing's and acromegaly, which already put stress on the insulin secretion from the pancreas. There may be an increase in the incidence of diabetes during the first years of growth hormone. And so we have to think about increased surveillance of glucose metabolism in patients that we start on growth hormone therapy. Diabetes appears also to be associated with body mass index as well as age in our patients. For patients who've had a previous pituitary adenoma or an existing adenoma, I think this data could be very important as well for the patients to know that in the Dutch registry, they looked at over 10 years of patients that had received growth hormone, and they looked at who had progression of their pituitary adenoma. So here you can see that about just over 10%, or 1 in 10 patients, showed that growth hormone, that they had tumor progression associated with growth hormone. Now that doesn't mean growth hormone caused it, but it just means that there were 10% of the patients on growth hormone that saw progression with a median time of 2.2 years of therapy. If patients had had prior radiation to the adenoma, they were at decreased risk. If they had residual tumor before they started growth hormone therapy, these are the patients at a little bit greater risk for progression. All in all, because as a pituitary doctor, I monitor my patients with residual tumor, this would be something that I would be able to catch if I started a patient on growth hormone therapy, and we could reevaluate the safety of the therapy for that patient. So of course, a big concern would be cancer. There are some big databases on growth hormone replacement. One is called KIMS. This is HypoCCS. You don't need to remember the database names, but to know that, for example, with the KIMS database, there were 100 patients on growth hormone with new cancer versus 325 that had deficiency. And no increased cancer was associated with normal IGF-1 levels. In other words, if you replace a patient using growth hormone and you keep their IGF-1 in the normal range for their age and sex, there was no increased cancer associated with this. If you look at the HypoCCS database with 6,418 growth hormone patients versus 1,268 untreated, over 5 years they identified 225 cancers that were new. But overall, the ratio approached 1. In other words, no increased risk. So the cancer risk was the same for both patients, growth hormone treated or untreated. Additionally, with pituitary adenomas, the recurrence rate was nearing 1. In other words, no increased risk. Craniopharyngiomas had a ratio of 1.32 or 132%, but this was not statistically significant. The one area where we do see possible risk for cancer is in those who have had childhood cancer and now have been replaced over the years with growth hormone because of deficiency. And the highest risk is seen in childhood cancer survivors that have had radiation therapy. Many of those tumors were meningiomas, but still there is a risk of a secondary cancer in these patients, and so we have to think very carefully about growth hormone replacement and depending on the risks of the patient. So just as I end my talk here, I showed you some evidence about effects of growth hormone in adults and who you would consider, but what's the truth here? The truth is that as a physician, our thought processes don't always turn toward the data. In other words, I don't go look up an article and go, I think my patient would benefit because that article says so. The types of patients I think about to start on growth hormone are those in which I have really worked hard with the patient hand in hand to optimize their hormone replacement therapies, excluding growth hormone. And I still do not achieve optimal day-to-day function in that patient. Also, I really have to think carefully about giving someone back growth hormone, that it could benefit maybe their body composition, less abdominal fat, improved LDL cholesterol, versus could I actually worsen their glucose or cause diabetes or even blood pressure problems in these patients, because these are significant cardiovascular risks. So we have to consider all of this as we move forward with growth hormone therapy. How do we start it? We start at low doses. We really have to pay attention to patient symptoms. Maybe there's some joint aches or pains. They could have swelling, edema. And we increase slowly. Here I say increase monthly to every 3 months, but I really am probably more of an every 3 months person. And we have to look at what other medications the patients are taking. For example, estrogen. Estrogen can increase the requirements for growth hormone dosing. And in older patients, we should consider lower doses as well. How do I monitor my therapy? Well, I want to make sure that my patient has had all of the appropriate cancer screening before I start the therapy, and that we continue to do the proper surveillance as proposed by guidelines. I always watch glucose and hemoglobin A1C, which is a measure of long-term glucose levels in patients, monitoring cholesterol and lipids, blood pressure, looking for fluid retention on examination, and for those that have a prior pituitary or have residual pituitary, I would do a periodic pituitary MRI. And I would aim for a serum IGF-1 that's somewhere in the mid to upper normal range as tolerated by the patient. And it's important to convey to the patients that it takes time. They're not going to feel like $1 million immediately. It may take months to even notice improvement, that they can't expect that this is a weight loss drug, but that it may improve body composition, and that we can still adjust the dose to the side effects that they might have. When do I throw in the towel? Well, if there's months of therapy and a patient has not improved, if they have uncontrolled diabetes or uncontrolled side effects that I cannot help with, if the patient develops cancer, and sometimes, unfortunately, our ability to prescribe growth hormone is dictated by insurance. On the horizon for growth hormone therapies are weekly injectables. Some of them are in trials now. If you go to clinicaltrials.gov, these are based on the fact that some of these vehicles will slow absorption of the growth hormone replacement or prolong its circulation. So perhaps instead of a daily injection, Patients will be able to move to a weekly injection, which would be more convenient. So I'll just finish with a brief case and I'll take questions. I say here when evidence meets anecdotes, because as doctors we always say we need to do evidence-based medicine, but occasionally we got stories, and this is my N of one. In other words, I got one patient. I have several patients on growth hormone, but this is probably the most extreme story that I have. This is a 78-year-old female who had a very large adenoma and surgery in 2008. I didn't meet her until 2012, and she came in with her husband. She was exhausted, no appetite, couldn't sleep properly. She even described herself as depressed. She complained of aches all the time, barely getting out of bed in the day. She was very thin, 110 pounds, very low body mass index, out of the range of healthy. And she'd been on at least thyroid medication since her 2006, which looked like it was caused by the tumor. And her cognitive changes were so extreme that she was actually tested by a neuropsychologist who thought there was evidence of early dementing disease. Antidepressants didn't work. She was put on stimulants to try and help her feel more awake in the daytime. And this didn't have any impact clinically for this patient. So I worked hard to try to optimize her pituitary hormones, optimized her thyroid levels. I established that she had adrenal insufficiency, thinking that could be the cause of the aches, pains, low appetite, and replaced her. And I still did not achieve very much. Every 3 months I felt like a failure when she'd come in and did not feel improved. So I looked up the literature and decided very slowly to try some growth hormone therapy. And she came for her 3-month follow-up with, I had the fellow in clinic and warned them this lady's not going to be very responsive. It'll be kind of discouraging, but this is a good example of the impact of the pituitary on overall health. And this woman walked in all jaunty, having gained 25 pounds, telling me she felt great, she was eating well, she was engaging, and that depressed affect I had seen when she first came to see me was now gone. And she continues now, I think, on her 4th year of growth hormone therapy. So at the end, benefits of growth hormone may be seen in patients with true growth hormone deficiency. The most important thing for me as an endocrinologist is to individualize the therapy, looking at the risk and benefit ratio, how to monitor for safety, and then of course to go back and reevaluate, is this really having a benefit in my patients? So I'm happy to take any questions now or listen to any comments.
Okay, thank you. That was excellent. We do have several questions. The first one, I was diagnosed with ACTH deficiency by insulin tolerance test and other modalities. My cortisone levels obviously did not increase with the insulin given for the test, and according to this test, neither did my growth hormone. I was asked to wait a year and then they would give me another test. I believe it was the Glucagon challenge test. My growth hormone was checked at baseline, 0.25, and then went down to 0.07 at 30 minutes, and again at 60 minutes. At 90 minutes, it was 0.15, still low. At 120 minutes, it was still low at 6.5. At 150 minutes, it went precipitously up to 9.26 and came down at 180 minutes to 3.97. I barely squeaked by on this test. I have the symptoms of GH deficiency. What would you advise?
So we do know that the growth hormone rise to the glucagon stimulation test is quite delayed, which is why we end up following the patient for 3 to 4 hours. So the fact that there was a late surge in growth hormone is not unusual here. And as I said, most of us will use a cutoff of 3 or even as low as 1 in our patients to look at growth hormone deficiency. I'm unclear on why the retesting. I'm not sure if there's other things that have been going on like radiation or something where the physician might think that growth hormone deficiency could be evolving. So as with all endocrine tests, glucagon isn't perfect either. Even, the insulin tolerance test isn't perfect, even though it's our gold standard. And you might request testing, repeat testing again. But I can understand the frustration of seeing what you would call a pass of this test from the literature and still feeling like that growth hormone deficiency might be something that you have.
Okay, thank you. I am a 66-year-old pan-hypopituitary patient following removal of a pituitary adenoma. I am taking hydrocortisone, levothyroxine, testosterone, and for the past 3 months, growth hormone. I have read that hydrocortisone dosage may need to be adjusted after starting growth hormone. What are the objective criteria to determine sufficiency of the hydrocortisone dosage?
So I don't actually measure the effect of hydrocortisone in the blood, so it does cross-react with cortisol assays. For the most part, it's really clinical. Does the patient now manifest new things like, okay, maybe they feel like they're kind of dizzy when they get up, or they've got vague nausea, decreased appetite, abdominal pain? We really reassess that on a clinical basis. So there's no test I can do. All I can do is listen to my patient in the clinic if something has changed in how they feel.
Okay, thank you. I am a 56-year-old male. In September 2012, I had surgery for pituitary adenoma, and my pituitary gland was also removed during surgery. I am on 30 milligrams Cortef daily, weekly injections of testosterone 0.4 milliliters, cabergoline 0.5 weekly, and 100 micrograms of levothyroxine. I have been on HGH for over 2 years. I am only able to tolerate 0.1 milligrams of HGH. Every time I try to increase the dose of HGH, I have severe muscle soreness. My last IGF-1 blood test was 71. Questions. Do some patients have a negative effect on HGH? Is there any test that can be done to gauge what the right amount of HGH is without side effects? Since the pituitary gland is removed, does my body still produce HGH? Thank you.
So those are excellent questions. So this is a very low dose of HGH. Some of that might be influenced by how a particular patient clears it. So maybe it's not metabolized as quickly. It does seem that the IGF-1 is probably on the low half of normal at 71. I don't have the particular lab or age-specific ranges that this patient has had. There is no real test. It really has to be done on a clinical basis. You have to listen to your patient in terms of their symptoms. And I do wish that I had a way to combat, the muscle aches and pains that some patients experience with growth hormone therapy so that they could further optimize their levels. But unfortunately, it is limited by those side effects in a few patients.
Okay, you mentioned that 3 hormone deficiencies plus low IGF-1 for age and sex is sufficient for a diagnosis of GH deficiency. Does central diabetes insipidus count as one of those 3 other deficiencies? And can you talk about the differences in diagnosing deficiencies such as hypothyroidism when the cause is hypopituitarism as opposed to a problem with the thyroid itself? Thanks.
Okay, so I think that when someone has diabetes insipidus after surgery for an adenoma or as another cause, this is one of the axes in terms of the different axes in the pituitary that is really the last to go. And in my opinion, unless there is infiltrative disease, which we didn't really talk about, but if this is because of a pituitary tumor, a craniopharyngioma, there has been significant damage to the pituitary, and I would absolutely include this as one of the axes, and I do write it down, especially on insurance approval forms. I think the second question is testing for hypothyroidism. So it's really interesting. I always have to train my fellows that normal, and I use quotation marks, normal range TSH and normal, low normal, 3T4, do not mean the patient is normal. Secondary or central hypothyroidism is very challenging to diagnose. You take into account the symptoms. Does the patient have symptoms of low thyroid, like weight gain, lethargy, fatigue? Then you look at the levels and you say, well, that T4 level is at the bottom of normal or even below normal. So even though the thyroid-stimulating hormone looks somewhat normal from the pituitary gland, it is inappropriate. So we have to be very vigilant that we're not missing central hypothyroidism in patients.
Okay, thank you. I spent several years with debilitating joint and tendon pain while I was on the dose of GH prescribed by my endocrinologist. There were a few weeks where I was unable to obtain GH and I noticed the pain went away. So I have since lowered my dose substantially in consultation with a different endocrinologist and have had no more pain. Are joint and soft tissue pain known side effects of GH replacement?
Yes, absolutely. So we do know from patients that have overproduction of growth hormone, acromegaly, from pituitary tumor, that they have significant joint pains and muscle aches. So this is a side effect that we hear from our patients. I've had the interesting, and I agree with lowering the dose when you're having those side effects. I've also found that there are some patients that they have more side effects depending on the brand of growth hormone replacement. There are several brands out there. I can't explain why that is because they're all recombinant growth hormone, but it may be with regard to how much they're absorbing or other things such as the vehicle, but I can't explain why those differences exist. So in some patients, I may try a different brand of growth hormone replacement.
Okay, interesting. Thank you. If GH is the first pituitary hormone to decrease when the pituitary is injured, why isn't IGF-1 tested first and a stress test done even before replacing other hormone deficiencies?
So the graph I showed was for radiation, but also for traumatic brain injury. But it doesn't mean that every patient fits into, perfectly in those categories. I've had patients with pituitary adenomas whose only problem is thyroid. I think if we can make sure that we optimize all of the different axes and do testing for cortisol, testing for thyroid, and testing for sex hormones, and if the IGF-1 is low, we shouldn't have to do a stimulation test necessarily. So I'm not sure if I'm answering the question here, but I agree that we've probably underutilized growth hormone stimulation tests in patients who have a significant clinical reason to have growth hormone deficiency. And I certainly have learned over the years to have a higher, what we call pre-test probability in medicine, meaning that could growth hormone deficiency be there based on the patient's history? And if the answer is yes in my head, and I think they would benefit, then I move forward on that.
Okay, thank you. Do you treat patients from other states like New Mexico, and will you work with my local doctors on implementation?
So we are a multi-state referral center here, and I see patients from many different states. Generally, patients will come down, have their surgery, and then I'll work with the local endocrinologist there. We certainly, there are many endocrinologists, and even I have patients in New Mexico as well, who are happy to work side by side if they feel they don't have necessarily the experience. And then sometimes I'm just happy to speak with them on the phone once in a while and see if they're not comfortable with certain therapies. So I guess I'm trying to say yes.
Okay, great. Thank you. I am pan-hypopituitary since 18. I'm 67 now and replace all hormones, including oxytocin. I have had an incidental meningioma for at least 15 years with size unchanged. How often do you recommend an MRI to follow?
So I would definitely leave that to your neurosurgeon. But I do think that would need to be followed on a regular basis. I think when we've had meningiomas in the Pituitary Center that my neurosurgeon has recommended, if he didn't know the growth trajectory, recommended 3 months and 6 months and then a year, but I would not make a recommendation. I would leave that to your neurosurgeon for that.
Okay. I have been a type 1 diabetic since 1954. My pituitary was removed in 1978 because laser surgery for diabetic retinopathy didn't work. You said that growth hormone replacement should not be given to someone with diabetic retinopathy. Why is that?
I don't know all of the physiology behind it, but I believe that there is a thought that growth hormone encourages blood vessel growth in retinopathy, and that is the problem in diabetic retinopathy, is out of control blood vessel growth, which can then cause visual loss.
Okay. I'm a 60-year-old woman and had 3-centimeter GH macroadenoma. Was pan-hypopit but no longer need DDAVP. I am on thyroid, methylprednisone, estrogen, and progesterone. However, GH was not replaced until 12 years later. Now, 16 years later, I am still unable to gain additional muscle mass and continue wasting. I inject 0.8 milligrams of nortropin nightly. Thank you in advance for any information.
Yeah, it's interesting for patients that have had a growth hormone tumor. There are some studies which have looked at, are there benefits to then replacing growth hormone after they have become deficient from the treatment, whether that's surgery or radiation. I don't know that maybe all of the symptoms could be attributed to growth hormone deficiency, so I think 0.8 is a pretty robust dose. Usually the max we would ever see in somebody is 1. So 0.8 is getting close to the max of growth hormone replacement in adults. And if the IGF-1 is also in that upper half of normal, there may be other reasons for difficulty with weight gain or muscle mass in this patient.
Okay, does Medicare cover growth hormone replacement therapy?
Yes, I think I have to. I'm trying to think back to some of my patients and whether they have supplemental insurance or not. I believe I have applied. You know, we have to do lots of forms, sometimes 16 pages, to get these things approved and show all the data. But I wish I could answer that specifically. I do have patients who are definitely over 65 on growth hormone therapy, but whether that is being covered by supplemental or not, I'm not sure.
Okay. 50-year-old Wernicke's encephalopathy survivor since 2015. No testing was done for a year, but results when done in 116 show no cortisol or testosterone. Started on hydrocortisone and TRT. IGF-1 was normal until a recent lab test showed IGF-1 at high for the first time at 209. There's a lot of talk about GH and TRT, with GH only considered for younger males. What would be your primary concern going forward?
I guess I'm not quite sure about the question. So the growth hormone actually, the IGF-1 was actually high? Is that, can you reread that?
Yeah, it says IGF-1 was normal until a recent lab test showed IGF-1 at high for the first time at 209.
So we do, so in spite of the fact in my talk I said that IGF-1 is a much more stable measure of growth hormone deficiency or growth hormone activity, we do see IGF-1 fluctuations in patients on the basis of, could be nutritional changes, changes in protein metabolism or diet, changes in weight loss or starvation. So with one IGF-1 level, like one snapshot, I don't think that I would jump forward to any conclusions and would probably look at that level again in a few weeks later. But I do see sometimes patients will have mildly elevated, that's a mild elevation, mildly elevated IGF-1 for nutritional reasons as well.
Okay, thank you. I was diagnosed with central diabetes insipidus in 2013, and I'm taking DDVP DDAVP, and it has been a lifesaver for me. In 2016, I was diagnosed with GH deficiency after taking the glucagon test in Miami. An MRI has confirmed that I have a thickening of the pituitary stalk. I live in Aruba, and I will be now flying to the Netherlands to do arginine testing as required by the insurance here. Is there any advice you can give me to make sure to ask the doctor in the Netherlands? I am feeling so confused and somewhat demotivated, and I have anxiety about flying there and the doctor telling me that I'm fine and I don't have GH deficiency. I don't know if I am overthinking it. I am very worried since my most recent CRP test came out 39 and the increased in cardiovascular issues increases with GH deficiency.
Mm-hmm. So that was a very long question. So it sounded like stalk thickening?
Yes.
At the beginning, and possible growth hormone deficiency.
Yes.
Can you read the end of the question again?
Yes. Okay. Do you want me to read the whole thing again?
Yeah.
Okay. Diagnosed with central diabetes insipidus in 2013.
Okay.
Taking DDVP. Diagnosed in 2016 with GH deficiency after doing a glucagon test. MRI confirmed thickening of the pituitary stalk, and he'll be traveling to the Netherlands to do the arginine testing.
Okay. Sorry, this is why I had to hesitate. Now I got it.
Okay.
I had to hesitate a little bit because I'm not hearing throughout that question that the reason for the stalk thickening has been diagnosed. So whenever we have diabetes insipidus, first, when someone manifests without another reason, you didn't have surgery for a pituitary adenoma, we have to think about infiltrative disorders. And that's a long list, and I don't mean to, bring up this very long list. But that has to be diagnosed first, and maybe it has been and it's just not in the question before we talk about any other kind of growth hormone replacement. You need to know what that is. So stalk thickening is not an adenoma. It could be another form of an infiltrative disorder. So I think if it's been diagnosed, great, and growth hormone therapy is safe, but before even considering that needs to be diagnosed.
Okay. Let's see. Next question. Dr. Samson, my father got his medical degree from Queens.
Oh, yeah?
Yeah. Let's see. My hypophysitis deactivated my pituitary gland completely. My endocrinologist at the time would not even test me for low GH. When I found an endocrinologist who would test me, my GH level was basically 0. The previous year was hell for me. I gained 30 pounds without binge eating and was in depression. 3 months of hematropin along with thyroid. Hello? Can you hear me?
Walden. I'm here.
Apparently we lost the internet connection there for a second over here. They're doing construction on our building. I don't know what happened, but for everybody listening, I apologize for that. Let me see if I can figure out where I was at with questions. Let's see. We already did that one. Keeps going back to the beginning. Let's see.
I think the last one I heard was the hypophysitis patient.
Right.
Dad went to medical school.
Father went to medical school. Right. Okay. So I think we're in the middle of that one. Okay, the previous year was hell for me. I gained 30 pounds without binge eating and was in depression. 3 months of hematropin, along with thyroid and other supplements, balanced my hormones and my natural body mass returned. I was able to ride my bicycle again. My endocrinologist made sure my GH level never went above normal for my age. Recently, in a routine blood test, I got a high PSA level. Is that in itself sufficient reason to stop hemotrope? What about a positive result from a prostate biopsy? Tomorrow I'm getting a biopsy, and so am playing what if.
Okay. I mean, this is an excellent question. So with regard to the hormone replacement, this should be assessed by a urologist knowing that you're on a sex hormone replacement, I assume testosterone. There are many causes of why a PSA can spike or rise. It doesn't mean there's cancer, but I understand the concern. But getting a biopsy done or whatever is the appropriate step based on the urology specialist viewpoint is very important. If there is an active malignancy, which I'm hoping there's not, then yes, this would be an indication where I, as an endocrinologist, would advise my patient to stop growth hormone therapy. Not because we know for sure that it has an impact on outcomes, but we certainly would not want to encourage any type of cancer growth in a patient.
Okay, thank you. After 3 pituitary surgeries for Cushing's disease, I have central thyroidism, DI, low aldosteronism, and low IGF-1. My doctor wants GH treatment for me. Insurance has denied. Any advice?
So I guess if it's U.S. insurance, I don't know the reason behind the denial. I will have patients come to the Pituitary Center that have had denials previously, and maybe their endocrinologist at the time doesn't do as much growth hormone therapy, and so they're not as accustomed to navigating the insurance companies and how you deal with this. I have been successful with some patients where they just have had no success elsewhere, and it depends about writing appeals. There are some patients that their insurance plans just don't cover growth hormone, and then that's the point at which you want to explore patient assistance programs with some of the pharma companies that make growth hormone. They do have these programs in place to help patients that don't have any coverage. So I guess I would say I'm not sure about why the rejection. Is it an insurance coverage exclusion, or was the data that was provided to the insurance company just not adequate? For example, did they want a stimulation test and maybe the endocrine doctor didn't have that particular procedure in place?
Okay, thank you. Thank you for this webinar. I was diagnosed in 1982 with childhood idiopathic GHD and re-RX'd HGH in 2012 after being off since 1995. It's a relief to know that studies are continuing for patients and we are not being left by the wayside. That was more of a comment than a question. If I understand you correctly, one of your first thoughts with CDI and GH replacement is to rule out any tumor or growth. Is this correct?
Sorry, one of the first, can you repeat the last part there?
Yes, one of your first thoughts with CDI and GH replacement is to rule out any tumor or growth. Is this correct?
CDI, is that CDI?
I'm not sure.
Central diabetes insipidus? Okay.
Oh, yeah.
Oh, with CDI, and then the rest of that sentence is?
One of your first thoughts with CDI and GH replacement is to rule out any tumor or growth.
Oh, so I think this was similar to when we talked about the stalk thickening. If a patient has isolated central diabetes insipidus, I think that you have to think much more broadly as an endocrinologist as to what that diagnosis may be. But yes, it would absolutely rule out something structural or infiltrative in the area of the pituitary before I would ever think about moving toward growth hormone therapy in the patient. I hope that's what that question is getting at.
Okay. As a child, I was diagnosed with GH deficiency in 1990. I was a head shorter than others my age and bone growth of 2 or more years younger from what I can recall. I took GH from age 5 to 12 when they said I should stop as I would reach my max height of a little over 5 feet. From what I've read, GH replacement today isn't stopped like it was when I was a child. Children continue to take it into adulthood. How can I find a doctor that specializes in adults with child-onset GH deficiency? When I was eventually referred to an endocrinologist for a different issue, she didn't believe me when I told her I thought I was still GH deficient. I had to fight to get tests done that showed that I was, and now I take GH as a choice. My doctor didn't seem very interested if I continue to take it or not. It's all up to me if I think it's helping. It's frustrating. Thanks.
Yeah. Our guidelines discuss that when someone has had childhood growth hormone deficiency, that, this may, resolve in adulthood, and patients may have an adequate IGF-1 level or growth hormone activity for an adult, which is much lower than you can imagine is in a growing child. So even though patients were deficient as a child, they may be adequate as an adult. But our guidelines tell us that these types of patients who transition from childhood through adolescence into adult endocrine care should be retested. And that before we even start. We don't just carry on with the growth hormone replacement. We should be retesting these patients to see where they're at. So I can see why that situation might be a little frustrating. And I think, we are becoming more and more educated about this issue. In the last 20 years, remember, we didn't have recombinant growth hormone until, the last 2 decades. And without that, we couldn't even think about replacing patients safely. So now we do, and now we're accumulating data both on deficiency as well as what are the benefits or risks of replacement. And so you just have to be patient with us as physicians, that sometimes it takes a while to educate us and get us on the same page.
Great, and I think this is our last question, more of a comment actually. Shouldn't we be starting a class action against insurance companies who exclude GH from coverage? It is becoming more common for both childhood GHD and adult GHD for insurance companies to exclude coverage.
I can make a comment to that, at least from my experience here in the U.S. It might surprise patients that it's not the insurance company excluding it, that the workplace where they get their insurance coverage has chosen a specific plan from that same insurance company and has excluded growth hormone replacement. So sometimes the activism is at the level of the HR department to say, we need to reconsider the type of plan that you're providing to your employees. So you'd be surprised by that, and where the problem actually lies. And sometimes it's with the employer rather than the insurance company. At least that's been my experience in getting replacement for patients, because they'll have the same insurance company and they all have different levels of coverage.
Interesting. Do I still produce HGH since my pituitary gland was taken out with my surgery for pituitary adenoma?
There are, I think, probably some tissues that make a very minuscule amount of HGH, or it might be expressed in some very, very tiny amounts in cell types. But when the pituitary is gone, no, patients don't make HGH. We can still see lowish levels of IGF-1 in some patients, which just may be the ambient production from the liver. Sometimes IGF-1 just isn't zero, but it doesn't mean that that patient has not lost all growth hormone. So the pituitary being, the production of 99.99%.
Okay. This is another comment to the other childhood GHD patient. I was prescribed due to severe hypoglycemia, check blood sugar maybe. I know I was passing out at work.
Mm-hmm.
Okay.
Interesting.
Yeah.
Yep.
Now I have several comments thanking you for the webinar. Several comments like that. I also had some questions about whether this would be available later. We are recording this webinar. It will be available on our website, pituitary.org. I'm hoping to have it up by the end of the day. I'll need to do some editing and get it processed first, so hopefully everything cooperates and I'll be able to get it up by the end of the day, hopefully definitely by tomorrow. And someone else asked if we would send it out. So I will email everybody with a link to our website and the information when the website is, or when it is available on our website. Dr. Samson, thank you very much. This concludes our webinar.
My pleasure.
for today. It was excellent information. Really enjoyed it. Always learn a lot during these. We appreciate all of you taking the time to join us and for sticking out when we lost our internet connection there for a little bit. We did get to all the questions, so we don't need to answer any of them by email. If you missed any part of the webinar, or if you'd like family or friends to see it, like I said, we will have it available on our website. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you all for joining us. Thank you again, Dr. Samson, and everybody have a great day.
Thank you. Bye-bye.
Bye.